The following podcast is part of a certified educational activity titled Navigating the ADC Roadmap for Modern Gynecologic Cancer Treatment. Expert Perspectives on Personalizing Patient Care. Access the entire activity and complete the post-test at peerview.com/MRT860. Downloadable slides and practice aids are also available.
Hello, and welcome to this educational opportunity entitled Navigating the ADC Roadmap for Modern Gynecological Cancer Treatment, Expert Perspectives on Personalizing Patient Care. Well, I'm David O'Malley, and I don't know if I can say I'm an expert, but I'm going to give it a heck of a shot today. And I'm honored to lead the Division of Gynecological Oncology at The Ohio State University and James Comprehensive Cancer Center in Columbus, Ohio. And I'm really pleased to be joined by my colleague, Courtney Arn, who's one of our GYN oncology nurse practitioners and really the key to the success of our team. Courtney?
Thank you. I'm glad to be here today. I'm looking forward to talking about the use of antibody-drug conjugates for the treatment of gynecologic cancers. We'll cover what these advances mean for our patients and share the perspectives for integrating their use in our clinic.
Sounds like a plan, Court. Let's get started. So really, let's talk about the goals today. We're going to augment the knowledge here. We have great people listening here today who are oncology practitioners across the country. I hope the globe. Okay, so we're going to augment that knowledge, equip our strategies to hopefully integrate the approved ADCs into clinical practice. We'll talk more about which ones, and then also provide guidance for the team-based strategies. We're only as good as a team, and we really need to talk about how we work together as a team moving forward to mitigate and manage these adverse events. And speaking of the team, we have Courtney, one of our amazing advanced practitioners. Other practices have physician assistants, of course, nurse practitioners, our oncology nurses who are taking all of these phone calls. Obviously, the oncologists, as we work through this, really being the interaction with the entire team, setting the tone of this multidisciplinary approach. Many of us also have specialty pharmacists, key to obtain medication access, to talk about some of these toxicities. I'll also pick up the phone and talk with people who have utilized these new agents. We also need our pathologist to get this information, like folate receptor alpha expression we'll talk about, like HER2 expression. We can't forget about our patient advocacy groups. These are really helping us get the information out to our patients with regards to this. And what patient advocacy groups do I send my patients to? Foundations of Women Cancer is a wonderful resource which really educates and supports our patients, not just from an educational standpoint, but also from a research and public awareness within GYN cancers. And as we look here, what are some of the others? NCCN, SGO, multiple American Cancer Society, multiple opportunities to really partner, as well as our own institutional patient education platforms. So, Court, we're hearing a ton about ADCs, probably about over 200 in development if we could look at all solid tumors. I mean, how are you talking with patients about ADCs?
Well, as the ADCs become more common, our patients are starting to ask us about them. If we're talking about a treatment change or if patients are coming in as new patients, they're often saying, hey, I've heard about this new drug class. Am I a candidate for it? Or is there an opportunity for me to be treated with the ADC? So it used to be us kind of talking to them about it, but now oftentimes patients are asking us if they'd be a candidate for it. Depending on their cancer type, any of their molecular profile, we talk to them about an ADC that might be a good option for them. And then we talk about the risk of that specific treatment for them.
And then how do we bring those in? How do we sequence? How do we do the testing? I think these are the questions. How do we educate ourselves about these new agents and some of these new side effects? So I think as we bring this in as providers, we need to continue to educate ourselves as we interact with our patients with shared decisions. So, and as we said, multidisciplinary, it takes a team. So what is an antibody drug conjugate? I'm not sure we still have to keep talking about this. I think we're going to start talking about the next generation and how important the linker is. I always thought linker was a bunch of crud. The linker is probably very, very important. It keeps the drug and the antibody together, connecting to that antigen in the cell, making sure we have expression. But we're seeing the difference in our expression levels, and we're really trying to identify what are these true biomarkers. And probably one of the most important is, what is the payload? Okay, what is the warhead which is destroying that cancer cell? And for me, I think, and I think there's some data which is starting to be generated, that the warhead is probably the more important. So do we only have one opportunity for an antimicrotubule? Do we have one opportunity for a topoisomerase inhibitor? We don't know that. We don't know that, but that's some of the information that we need to pay attention to, particularly when we're talking about sequencing. We're going to spend most of our time talking about tisotumab vedotin. Okay, I refer to as TV. A lot easier to say TV than tisotumab vedotin, right, Court? So we have, and then mirvetuximab soravtansine. Again, much easier to say Merv. But we've also seen trastuzumab deruxtecan with TDXD in some exciting data from there. We'll touch on briefly on that. So we're going to concentrate most of our time here talking about TV and MERV, both as cervix and ovarian cancer approvals. Both of them very similar in 2024 for full approval. TV was about just short of a year earlier when they obtained accelerated approval in cervix cancer, followed by MERV 2022 with accelerated approval, both of them obtaining full approval in 2024. We'll talk about that data. So let's start with TV and cervix cancer. Again, the mechanisms of action here, we've already talked about an antibody drug conjugate. This payload is MMAE, okay, which is an antimicrotubulin. So important to keep in mind, both the drugs that two of the drugs we're going to talk about, today, are antimicrotubulins like the taxanes, right? So tissue factor is really ubiquitous within cervix cancer patients. So there's no biomarker here because almost all are expressed. So as we look at the data that led to the full approval, this was the phase 3 Innovate 301 trial. It took patients who had recurrent cervix cancer, previously been treated with a platinum doublet with or without BEV, and an anti-PD-L1 agent if they had access to it from the area they were from, and then looked at TV, okay, at 2 mg per kg every 3 weeks versus investigator choice chemotherapy. And the topotecan, vinorelbine, gemcitabine, irinotecan, and pemetrexed were the 5 agents that we could use. Okay, mostly we use pemetrexed, but there's very good options there. And the key endpoint here was overall survival, with secondary endpoints of PFS as well as overall response rate. And you see here on the left, overall survival, and this is really where we saw a 2-month improvement, but you have to be always careful when you're talking about medians, okay? Clearly the separation of these curves, both in the PFS and the OS, with hazard ratios right at about 30% improvement, 0.7. But once again, clear separation of these curves from really the first cycle and then staying apart. And unfortunately, we see them coming together, but clearly patients living longer with the utilization of the agent. So why are they living longer? Well, they respond better. Investigator choice chemotherapy, 5.2% objective response rate, 5%, versus about 18%, 17.8 to be precise, who had a respective objective response rate to TV. And with that, disease control, which I don't love, that's about 76% versus 60%, but disease regression, more people than not had disease regression in the TV, with only, I guess, just over a third in the investigator choice chemotherapy. So these patients who are often symptomatic need disease regression. You have much higher rate utilizing TV. And can we combine with other drugs? Well, Virgo published the experience in our kind of multi-arm phase 1/2 trial, looking at the combination with carboplatin in the first line, Pembro in the first line, and then choice that I will sometimes utilize, which is in the second or third line TV plus Pembro, particularly if patients have not had previous Pembro. Again, response rates in the first line, 40 to 55%, but in the second line, 35%. And that's in patients who had previously not had Pembro. So, Court, lots to talk about safety. Could you walk us through some of the considerations with TV?
Sure. The most common adverse events that are associated with TV were ocular, peripheral neuropathy, and bleeding. As you can see on this slide, most of the AEs were grade 1 or grade 2, with very few of the patients having a grade 3 AE, and there were no grade 4 or grade 5 AEs associated with TV. Also, only about 5% of the patients had to discontinue treatment because of ocular or peripheral neuropathy event. First, we're going to talk about ocular AEs for TV. It occurred in about 50% of the patients. The most common ocular AEs for TV were conjunctivitis, keratitis, and dry eye. We're mostly seeing the conjunctivitis for these patients. Because of the risk of ocular toxicity, we've implemented mitigation strategies to help prevent the ocular AEs and help manage them. So first thing you want to do is refer to an eye care provider. It can be an optometrist or ophthalmologist, but you want to make sure that they have their baseline eye exam, and then they need an eye exam including slit lamp and visual acuity prior to every cycle of TV for the first 9 cycles, or as clinically indicated. So after the 9 cycles, if they're not having any ocular AEs, they only need to see an eye care provider if they're having any symptoms. Once they've had their baseline eye exam and deemed okay to start treatment with TV, the first thing you want to do is prescribe their eye drops. For TV, there's 3 eye drops. You're going to prescribe a corticosteroid eye drop, a vasoconstrictor eye drop, and of course the lubricating eye drops. The corticosteroid eye drop and vasoconstrictor eye drop, they receive immediately prior to the TV infusion, so they do need to bring these eye drops with them to their appointment. The vasoconstrictor eye drop is only used immediately prior to the infusion. They do not use it at home at all. The corticosteroid eye drop is kind of the rule of 3s. So they're going to use it 3 times a day for 3 days. So immediately prior to the infusion. And then I usually say, like, once you get home and settled, use it again. And then again that evening. And then they'll do it 3 times a day for the next 2 days. So 3 days total. It's also important to use cold packs. The idea behind this is, TV binds to the tissue factor, and there's tissue factor in the eyes. So we can vasoconstrict that area by using the cold packs. We can hopefully decrease the risk of having these ocular AEs. So while patients are getting treated with TV, you want to make sure that they have a cold pack on their eyes about 10 minutes before the infusion. They need to keep it cold the entire infusion, and then about 20 minutes after the infusion. Using these mitigation strategies, we're hoping to decrease the risk of ocular AEs and then hopefully minimize them as well. The other 2 common AEs with TV are peripheral neuropathy and bleeding. The peripheral neuropathy can present a little bit different than the typical numbness and tingling in fingers and toes. It can sometimes be more of a motor weakness or a sensory motor peripheral neuropathy. So you want to make sure you're not only asking your patients, are you having numbness and tingling in your fingers or toes, but you also want to kind of assess, have you noticed any changes in their strength? Oftentimes their partners or family members will say they're having a hard time opening jars, or they're asking them to do things that previously they were able to do on their own. Or sometimes they'll notice a change in their gait. Dr. Malley and I like to really watch our patients walk in and out of clinic, because while sometimes patients will say, I'm not having any pain or numbness or tingling, we can kind of tell by the way they're walking that they actually are. So you really want to observe for any type of atypical peripheral neuropathy for these patients, as well as the, normal numbness and tingling. Prior to starting TV, if a patient has pre-existing neuropathy, you want to make sure that's well controlled prior to starting TV. Or if they develop new or worsening neuropathy, you want to make sure you're holding, dose reducing as needed, but also make sure you're optimally managing it with pharmacologic agents, referring to physical therapy, using creams, things like that to help minimize the peripheral neuropathy. But talk to them about peripheral neuropathy prior to starting TV. Every visit they come in, make sure you're asking questions, but also kind of observing their motor skills and their ambulation, and then just make sure that you're holding, dose reducing, or discontinuing depending on the severity of it. The word bleeding is much scarier than it actually is. The most common bleeding event was epistaxis, which we're all familiar with other agents that we've been using. And it's really no different, other than it doesn't seem to be as accumulative. We see it kind of early on. It's usually really mild. As you can see, most were grade 1 or grade 2, with less than 1% of the patients having a grade 3 bleeding event. Make sure you're doing the conservative measures for the epistaxis, referring to ENT if needed. But again, it's usually pretty mild and early on and not something that persists throughout their treatment. We've also seen hematuria and vaginal bleeding. You, of course, want to assess your patients for any increased bleeding factors prior to starting treatment with TV. Go over bleeding precautions with them. But again, it's mostly mild and we're not needing to do that, but just make sure they're aware of the risk and what to do if they do have any bleeding. And assess your patient. Are they at high risk of bleeding? Are they having vaginal bleeding from their disease? Are they on anticoagulation that could increase their bleeding? So if they're having these bleeding episodes, just make sure you're assessing for any other causes as well.
So, Court, you're like a magician with regards to these symptomatic controls, and one of the things you said were cream with peripheral neuropathy. I mean, what kind of creams are you recommending for peripheral neuropathy?
Well, sometimes the neuropathy, like I said, can present a little bit differently, and it's not necessarily numbness and tingling, but it can be more of like a pain when they're walking. And we've been using like a Voltaren gel that really helps with that discomfort that they're having. Other patients, just use like over the counter, like moisturizer if they're having any pain on their feet. But for the most part, the Voltaren gel has been really helpful for some of that discomfort that they're having.
And the eye toxicity with TV, which is, I think, different than some of the other ADCs, is usually conjunctivitis. I mean, they walk in, their eyes are red. It's not subtle. I mean, we'll see some keratitis on the opto examinations, but with a little bit of blurred vision, it really is just my eyes are irritated. So even a GY oncologist can really do the eye exams. Are they red? Are they irritated? And then we can intervene as is. So some great, great, great practical things there.
Some care insights that we're using. So, our nurses, whether it's the infusion nurse or clinic nurse, have implemented this smart phrase that's been really helpful. So, in the past, chemotherapy, we get their labs, we clear them for chemo. That's kind of what we're looking at. The preparation for these patients and the management is a little bit different with some of these newer agents that we're getting that have different AE profiles. And so, our nurses are using a smart phrase that says, are you having any new ocular symptoms? Did you see the eye care provider? Are you using your eye drops? Did you bring your eye drops with you? And this kind of works as a hard stop for the providers and the patients. We're making sure we're assessing for any ocular symptoms. We're making sure they're using their eye drops right and they had that eye exam because, it's preparation ahead of time. We need to make sure if they saw the eye care provider, we have that note from the optometrist or ophthalmologist to make sure that there haven't been any changes in their vision. So this really works as a reminder for all the providers to make sure that we're assessing for the ocular toxicities, because a lot of times it's not built into that initial toxicity assessment that we've been doing for chemotherapy treatment options in the past. So that's really worked at our practice, and it's just a good reminder for the pharmacy, the providers, the patients, the nurses to make sure that we're doing everything. We're talking to them about the ocular symptoms and make sure that they're seeing the eye care provider and using the eye drops as we should. Anything else, Dr. Melly, that you feel like we've done differently at our practice for?
I think, right, handing them the form, the patient the form, literally printing out the form and saying, take this to your eye specialist. So, I think that to me has been one of the most easy, practical, and, maybe I'm old school and like a piece of paper is to me still is a good way to communicate.
Yeah. No, I forgot to comment on that. So what we do is, for TV, they need 9 eye exams essentially, well, 10 if you include the baseline. And so we just print them all off. I write the cycle number at the top. We also, if they're seeing a local eye care provider, we fax that ocular assessment form with the referral. So the eye care provider has it, but I also have the patient take it in. They generally fax us the report, but I always tell the patients to bring it in too, just in case. And then we review it right there with them at their visit and make sure that we don't need to do any dose modification based on their eye exam.
Well, let's switch gears here a little bit, Cord. I mean, we it's a great discussion about TV, great discussion about good practical things. Again, handing them the form, educating, then just then uploading it for those who use electronic medical record. It's right there with the date. So let's switch gears here a little bit from cervix and move to ovary. Targeting folate receptor alpha is again, it's not ubiquitous like we see in tissue factor, but it's probably 80% of high-grade serous ovarian cancer. Now, about 35 plus or minus 5%, 40 plus or minus 5%. So somewhere in there, that's really when you look at the high folate receptor alpha expression. But you kind of break that down. Now, MERV, again, is an antimicrotubule, but instead of for its payload, but instead of MMAE, it's DM4. So again, very similar in with regards to an antimicrotubule. And we first had it approved based on SORAYA back in 2022, which showed an objective response rate of 32%. Tumor reductive, this is what I was talking about earlier on the TV, 71% tumor reduction. And if they got a response, the patient, had a response, that response median duration was about 7 months, and then got a little bit longer as we look back at that. At the same time that SORAYA was reporting, MIRROR-SOL was completing enrollment. In MIRROR-SOL, remember, only high folate receptor alpha expression using the 2+ scoring, so 75% of cells with 2+ or more. And then it randomized 1-to-1 MERV versus investigator choice. In this case, is weekly paclitaxel, pegloticosome doxorubicin, or topotecan, with the primary endpoint being PFS by investigator. And for the first time ever, on the bottom Kaplan-Meier curve, we showed survival advantage in platinum-resistant ovarian cancer. Really quite modest. Again, this is why I don't like medians. The median progression-free survival is only 1.5 months. But the hazard ratio, looking at the totality of the curve, is a 35% improvement. And look at how, once again, those curves separate really at the first cycle. Before the first cycles, the first assessment, right? You see clear separation of those curves. Okay. So again, 33, 35% improvement depending on OS versus PFS. Response rates. This is the other thing. These patients in platinum resistant are often symptomatic. 42% overall response rate, 42% overall response rate versus 16% for investigator choice, very consistent with the historical data on single agent chemotherapy. We also looked to evaluate MERV in platinum-sensitive disease. So Angeles Alvarez-Socord led PICCOLO, which is a phase 2 trial in platinum-sensitive patients who were eligible for single-agent therapy. So these are patients with high hypersensitivity, maybe they weren't able to get any more platinum, or patients who potentially had hematologic toxicity, which you didn't want to use platinum. So you're using single-agent MERV. And the response rate in this population was really interesting, which was 52% response rate. Many of them had been previous PARP, where we also saw a very nice response rate, even those patients who had progressed on PARP. So interesting it is. MERV-BEV is listed on NCCN, and I was honored to lead forward too. It's really reported on MERV-BEV. But that MERV-BEV data led to the design of Glorioso, which is ongoing and enrolling right now, which looks at MERV-BEV versus BEV in a maintenance setting in platinum-resistant patients with high folate receptor alpha. And that's ongoing. We're hoping to have that enrolled by the end of this calendar year, looking to move MERV up in patients with platinum-sensitive disease. Court, a lot of the same things with regards to eye toxicity and some of the safety concerns here, but very different. Conjunctivitis, right? Versus keratitis and blurred vision. So walk us through some of the toxicities that we see with MERV.
Sure. So as you can see on this slide, the hematologic risk for MERV is much lower than the chemotherapy arm, but we did see some neutropenia, anemia, and thrombocytopenia with MERV, but much lower risk. The more common AEs for MERV were peripheral neuropathy, diarrhea, nausea, and then of course the ocular AEs, including blurred vision, keratopathy, and dry eye. As far as the hematologic, just routine, CBCs prior to their treatment, holding, dose reducing if needed, but pretty low risk of, having hematologic toxicity with the MERV. But you still want to keep an eye on their CBC results in other labs. As far as the peripheral neuropathy goes, it is a little bit more consistent with MERV with, the numbness, tingling in the fingers and toes, but we also see some like arthralgias and myalgias with MIRV. So again, ask about the numbness and tingling, but make sure you're asking about like joint pain, muscle aches, things like that for your patients who are coming in for their clinic visits as well. It's managed pretty similar to, any other peripheral neuropathy. You want to make sure you're holding, decreasing the dose as needed, but also utilizing those other things like the pharmacologic agents we talked about, the creams, referring to physical therapy, and just talking to them about new or worsening symptoms to be calling and reporting. Make sure you're quick to hold treatment if needed to prevent it from getting worse. With MIRV, we've really seen just holding a week or two, we can see pretty significant improvement in their peripheral neuropathy. So just make sure you're asking them about it. Make sure you guys are talking about different mitigation strategies to help with it as well. As far as the diarrhea, it was about 29% of the patients. It's not severe diarrhea that we're seeing. It seems to be, for a few days after their infusion, and then it improves. So we oftentimes will do like scheduled or prophylactic antidiarrheals for our patients who are having it. We don't usually do it up front because some of our patients have baseline constipation or they don't develop diarrhea from the MIRV. So we wait and see how the first cycle goes. If they develop diarrhea, we're quick cycle 2 to kind of add in that antidiarrheal. Usually the day after their treatment, I have them take it once a day for a few days after treatment to try to prevent the diarrhea from happening. But again, a lot of patients aren't having any diarrhea from the MIRV, but just be aware that it is a potential side effect and usually very well controlled with just doing a little bit of an antidiarrheal for a few days after their treatment. It's not usually indicated long-term, like the whole 3 weeks in between, but if they do need to use it as needed, they can. So just make sure they're aware of that risk. Make sure they have an antidiarrheal at home if needed. As far as the nausea goes, it occurred in about 27% of the patients. We use pre-medications prior to giving their infusion, and then we also send them home with antiemetic to have on an as-needed basis. Clinically, I don't think our patients are having that much nausea, but we still talk to them about the risk of it. We still use the pre-meds to try to reduce the risk of it, and then make sure they have an antiemetic at home if needed. Make sure they're, doing the small frequent meals, lots of fluids, and then calling if they're still having nausea despite taking their antiemetic. But it doesn't seem to be too big of an issue with MIRV. The most common ocular AEs, like Dr. O'Malley alluded to, are blurred vision, keratopathy, and dry eye. Similar to TV, we want to make sure these patients have an eye exam prior to starting treatment with MIRV. The difference with MIRV and the eye exams is it's every other cycle for the first 8 cycles. So a little less eye exams compared to the TV, but you still want to make sure you have the baseline every other for the first 8 cycles or as clinically indicated. So if they're having ocular symptoms in between, make sure you're getting them in to see the eye care provider. Or if they develop ocular toxicity beyond the 8 cycles, again, get them in with the eye care provider. But we're generally seeing it early on between like cycles 2 and 3. And if they've made it through the first 8 cycles without ocular AEs, we very rarely see it beyond that. The eye drops are also a little bit different for MIRV compared to TV. You don't use a vasoconstricting eye drop with MIRV. It's a little bit, there's some discussion as far as the role of steroid eye drops for MIRV patients. Previously, we were using steroid eye drops for our patients. It actually starts the day before their infusion, so this is different too. Again, this kind of goes back to those like strategies that we're using for our care team. All the nurses need to be aware. Eye drops the day before. Make sure you're counseling your patients on that. Initially, we were calling our patients the day before, making sure they got their eye drops, they started using them, because that's a little bit different than, a lot of the treatments we've done in the past. So the day before, 6 times a day, and then they do that through the day before through day 4, and then 4 times a day, days 5 through 8. There has been some discussion of how much benefit the steroid eye drops are providing for these patients, and there's also that's combined with the risk that it could increase the risk of cataracts or intraocular pressure. So most recently on one of the Gloriosa, the clinical trials we're using, we are not using the corticosteroid eye drops, and so far we have not seen an increase in ocular toxicity with omitting the steroid eye drops. And so I think it's a risk versus benefit. If you have a patient with known cataracts or concern for intraocular pressure or any other concerns with using corticosteroid eye drops, don't feel as strongly that you're using the steroid eye drops, but we were using them on the clinical trial that helped get MIRV approved. So I think it's kind of a patient-provider discretion of whether or not using the steroid eye drops. Dr. Malley, anything you want to add about that?
Well, I think you alluded to it, which is it's pretty consistent. It's about cycle day 10 to 14, excuse me, cycle 2, day 10 to 14. It's pretty consistent. I mean, you can see it any time, but that's when we really tell patients when that cycle 2 counseling about, a week to 2 weeks, you may notice that you're having blurred vision. And then, so they're not completely freaked out if they suddenly are having trouble, reading at night or even seeing the television at times. So I think we look at that and then mitigate from there. What's really interesting is their steroid eye drop. The original cohort where we instituted the mitigation strategies way back almost 10 years ago, we overall numbers were slightly decreased to the eye toxicity, but we really saw a marked decrease in the grade 3 toxicities. So I think there is something there, but again, with Gloriosa not requiring them, we're getting a little bit more comfortable not utilizing them all of our patients, especially those with pre-existing cataracts and some other or intraocular pressure. So I think this is kind of part of the discussion. Currently, we're still favoring, like we talked about, right? We're still favoring it, but yet if people start to have some issues, feeling very comfortable dropping the steroid eye drops as a prophylactic. If we do have interventions, then we work very close with our side effects, not interventions. Then we work very closely with our eye toxicity experts, our ophthalmologist, and we have a couple who have special interest in ADCs that we refer all of our patients to, which really helps us and try to mitigate and keep patients on an effective dose and keep them on treatment, especially when they're benefiting with platinum-resistant ovarian cancer.
So, although TV and MERV have a much different mechanism of action, there are some similarities with the ocular AEs. They can present with different AEs, like we talked about. TV being more common for the conjunctivitis, keratitis, dry eye, whereas MERV, we're seeing more of the blurred vision, keratopathy, dry eye. So there's some overlapping ocular AEs, but they can also present differently. The timing of onset is pretty similar as well. With TV, we're seeing onset of ocular AEs between like 1 and 2 months. Again, MERV, it's 5.4 weeks, so it's really between that cycle 2 and 3. So both of them can happen early on. I think this is an important discussion for the patients too. Some of them, the chemos they've been on before, the treatments they've been on before, they've had to get 5 or 6 cycles before they develop an AE. We're seeing the ocular AEs early, so make sure they're aware that it can happen, within those first 2 to 3 cycles. Both TV and MERV have a high reversibility rate, meaning like most of the ocular AEs were resolved or significantly improved after discontinuing the treatment. So that's similar for both of them. Of course, the eye drops are different for TV versus MERV, which we've talked about extensively. TV, you use the cold packs, whereas MERV, you do not, and that's because of the mechanism of action. Both agents, you need to avoid wearing contact lenses while being treated with the ADC. You want to utilize the eye care provider for both agents as well, getting the baseline eye exam, referring to them. Don't get too worked up in like the grading of conjunctivitis or the keratopathy, what that means, what their grade is. Rely on your eye care provider. Use those ocular assessment forms. It's very specific and easy for them to fill out. If they're having keratopathy, the eye care provider needs to identify based on the exam how severe it is, review that, and then decide whether they can get treated that day or if you need to modify the dose. Don't get too worked up in what the different ocular AEs are. Just what is it? How severe is it? And is it okay to give treatment today? Really rely on your eye care providers. Our overall impression, like they've been really excited to be able to help out. They kind of do the same thing all day, every day. And so doing something different, they feel really happy to be able to help these patients during their cancer journey. So make sure you're using them, make sure you have close communication with them, make sure they're aware of that form to fill out. Because if they fill that out, it's really easy to see, are they having toxicity that's okay for treatment today, or do we need to make dose modification? Also talk to your patients about eye hygiene. Make sure, again, they're looking in the mirror, calling you guys if they're noticing any appearance changes or also any ocular AEs or symptoms that they've noticed since their last visit.
Let's change gears a little bit here and talk about TDXD. This has NCCN guideline therapy now for over a year, and we also have the accelerated approval on 3+ agnostic. And TDXD again, topotecan payload, and against HER2. So we now check HER2 on everybody. IHC, we use the gastric type criteria. We check on everybody. And you see here pretty impressive rates at 3+, and that's why they have the agnostic. The NCCN used 2 and 3+. The data in 1 and 2+ doesn't really look much different, but obviously the response in 3+ has been really, really impressive. And one of the things we've learned, Court, pneumonitis, pneumonitis, pneumonitis. So tell us about the 5S's.
So the 5S rule is a really good tool to help identify and manage pneumonitis. This is kind of developed for TDXD, but it can be utilized for any of these ADCs that can increase the risk of pneumonitis. Number one is screen. So you want to assess your patient prior to starting TDXD if they have increased risk factor of having pneumonitis and if they need closer observation or palm referral prior to starting treatment. Number two is scan. We've really learned that frequent imaging of the chest has been helpful in early identification and management of ILD. So make sure you're getting the baseline imaging, and then it's recommended to get CT chest every 6 to 12 weeks while being treated with TDXD to identify ILD. If they're not having any symptoms, we've definitely seen where we picked it up on imaging, even in these asymptomatic patients. And it makes a big difference, early intervention, rather than waiting until they become symptomatic. Number three is synergy. You have to make sure all healthcare providers, nurses, pharmacists, everyone's aware of the risk of ILD with TDXD. Make sure we're all, assessing these patients, talking to them about the risk. If a patient's calling in with cough, shortness of breath, starting from that very first encounter, if it's the nurse, whoever's taking that call, make sure everyone's aware of the risk and making sure we're quickly intervening if there's a possibility of someone having ILD. 4 is suspend treatment. So depending on the severity, you want to make sure you're holding, dose reducing, or permanently discontinuing TDXD depending on how severe their ILD is. And then lastly, number 5 is steroids. So if someone's identified to have ILD, make sure you're treating them appropriately with steroids.
So why did I say pneumonitis, pneumonitis, pneumonitis? Because not that it's the occurrence is that high, it's 20-ish%, plus or minus, maybe only 15%, but not identifying it can lead to patients having very bad outcomes. So that's why we took a few extra minutes here today to talk about the 5S's. The treatment landscape for GYN cancer patients really is an ADC landscape right now. We're looking at the next generation, but right now, treating our patients ADCs. Different ADCs have different toxicity profiles, obviously different indications. We don't have to get into that. Educate the patients. Educate your nurses. They're taking the phone calls. Don't have the patient who develops shortness of breath and difficulty breathing be told they need to see their primary care doctor if they're on an ADC. You have to be thinking pneumonitis. Everybody has an important role here. Don't forget about educating your patients and their family members. You heard Courtney say, educating the family members and provide them resources which they can reach out, like the FWC, to get more information. Courtney, that was great discussion, man. It's so amazing to work with you every day, to team together to take care of our patients, to mitigate side effects, maximize our outcome for our patients. What final words do you have for our group today?
I think the biggest takeaway is, we're continuously developing these new agents for our patients, and we want to make sure our patients have access to them, but we want to make sure we're doing it safely. So make sure the entire team is aware of the AE profile. Make sure you're implementing these strategies to prevent the AEs from becoming severe or intervening quickly to help manage the patients, to get them access to these treatments, but keep them on the treatment longer.
Wonderfully said. Thank you to all of you for joining us today. I'd like to remind you to please download the practice aids associated with this educational activity as a resource for you, your staff, and your patients. We hope that you found this activity informative and useful for your practice. Thank you very much.
Thank you for listening. Remember to download the slides and practice aids and complete the post-test for instant credit. This activity is certified by PVI, PeerView Institute for Medical Education. This activity is developed with our educational partner, the Foundation for Women's Cancer. This activity is supported by independent educational grants from AbbVie and Pfizer Inc. and Genmab. To access all materials for this activity, visit peerview.com/MRT860.